There you go.
Anyone recognize this picture? You better not. Does anyone know what a Hast eagle is? Anyone?
It's New Zealand.
It's in New Zealand, that is right.
It's a famous vulture slash eagle.
Bird of prey we call it, but that's all right. Largest bird of prey ever. Wingspan 9 feet, unbelievable beast. Anyone seen one recently? You have. Besides this picture?
No, it was a wax.
Yeah, because? Okay. Kind of killing my talk here, but that's all right. Why is it extinct? Why is it extinct?
Because it ran out of food.
What? And these are called the moa birds.
Yeah.
And the moa birds are flightless birds, and we'll just call them turkeys. And man came around, and what did man do?
Ate the moa birds.
Killed the moa bird. So this big, huge beast, most dominant bird ever, extinct. You do not want to be the Hast eagle. Okay, cardiac surgeons in my generation are the Hast eagles. They refuse to adopt and change, and they missed the boat with interventional cardiology. So with that said, is in neurosurgery, we have absolutely evolved. And this goes back to what I'm saying about you guys. One of my attendings, a guy named Bill Buckeye, said, when I retired, I didn't do a single procedure I was trained to do when I started my residency. So remember that. X-lift, you have to adapt and change. So I'm just going to say that. And now with that, in order to do that in your generation, you have to understand what value is. Who knows what value is? Charlie? All you have to do is read the slide. Not a lot of pressure on you.
Quality over cost.
Quality over cost. That's very good. I was kind of straight. You know, you are from Baltimore, so I was a little nervous that you would get the big words. All right. So what we're going to do is first we're going to look at quality, and we're going to look at lumbar spine fusion. And I did this project, and we'll go into that really quickly. And then second, we're going to go into costs, and we're going to look at what's one of the simplest procedures we do. ACDF, right? ACDF, pretty easy. We all do the ACDF the same way, right? Cut out the disc, throw something in there, put a cap. It's got to be pretty easy. So we're going to look at the costs. Should cost the same everywhere. But before we go this, I'm going to throw out some words that you guys need to know. This is our gross national product, or domestic national GNP or DP. You'll see the same thing. It means the same thing. This is the U.S. cost. Do any of these work? All right, whatever. The U.S. actually has the highest incidence and highest gross. We use about 21% of our healthcare, of our national product on healthcare. That's a lot. That means 1 out of every $5 goes to pay for healthcare. Is that a good thing or a bad thing? Bueller? It's a good thing. It's a good thing if you're getting value. Exactly. If you're not getting value, it's a bad thing. So again, Charlie told us what it is. If you notice, the killer is COVID killed a lot of countries in the last year of this peak. So this is a very interesting concept, and I'm just going to explain it. It's the end of the day, and I'm going to try speeding this talk very up for you guys. And if someone's got a timer, let me know when I'm like 45 minutes into it. So what you want to do is when you look at something, these are the means, right? I went through the means of different areas. You want to be in the uppermost left-hand corner. If you're doing quality improvement stuff, you want to be high quality, low cost. That's where you want to be. In this thing, you want to be, Israel's a good place. You want to be them. You don't want to be, oh my God, the U.S. So we suck. We're spending 21% of our value, and we're not getting value. You can live 4 times longer than the U.S., 4 times cheaper in, I don't know what country it is, Israel, for the same quality as the U.S. That's not good. Now, you guys are going, well, that's because we invent medicine and everything. I don't care what metric you looked at in quality improvement, you got to get over it. We waste a lot of money. If you look at infantile birth, this is life expectancy. There's about 25 different things people look for quality metrics. We lag all of them. So that's what we need to do, is we better understand what we're getting value. So who has Epic? I would imagine most of us have Epic in academic things. You can see the price of every single thing you use in the operating room. Did you know that? When Adam's my fellow, okay, when Adam uses a yellow bipolar, I go bullshit. Why? It's $500. So Adam knows I'm not going to use it in my room, but in Dr. X's rooms, the residents will use every funny thing they can, because guess what? I was a resident, and it's not my credit card. What do I care? I like the yellow bipolar because it's a little, it's faster, whatever. All right. Next thing we're going to talk about. Who uses post-ACDF? Who uses cervical orthosis? Raise your hands. Okay. I do. I'll be the first one to lie. You guys are all liars. Whatever. I gave this another time. So let's look at that. What is the value of it? Is there any data about cervical collars? Paul Anderson, great guy, smart guy. There is no clinical difference in outcomes if you use a cervical collar or not for a 2-level ACDF. Why do we do it? And again, I'll be the first one to fall on the knife. I use it because I was trained to do it. Everyone else in Philadelphia does it, but you don't need to do it. So then you go back and you go, well, let's look at the costs. Well, the patient doesn't like it, restricted, skin breakdown. The hospital do well with the cervical collar? How much does a Philadelphia collar cost? Your hospital charge?
I'm not sure, $80?
No, that's not even close.
$200?
Between $300 and $900.
Oh,
Okay, and you can go check my numbers on you or whatever. How much does it cost on Amazon? $28. Very good job. And actually, this came to true with me. My wife broke her ankle, so I went to the Rothman Institute, had to get a cast. $800 freaking dollars. $800. They gave her the wrong cast, the wrong boot. So they're like, no, you want a short boot. So we're like, well, can't we trade it? And they're like, well, you wore it. And I'm like, great. I got an $800 plant holder. So I'm like, well, how much it goes? Let's go on Amazon and get one. $50. And I'm like, it's the same goddamn boot, except for it's shorter. And I'm like, why would it and I don't get it, but start questioning these things, because that value is going to someone. It's either going to the insurance company who's making billions of dollars, the hospital system, or whatever. So the hospital also doesn't want to have things change. So really quickly, we're going to go through this. This is a paper we were on guidelines, and we started it for a couple reasons, 3 reasons. Remember, you're gonna have questions. It's great as a resident to remember your questions. This was when I was probably just I don't know when this was, 2000. When I was just starting out as a attendant resident, this paper came out. Jim Weinstein, one of the brightest guys. He was the editor of Spine, genius guy. And what he did is he took out 136 Medicare populations, okay? Medicare breaks up in the country in different regions. And then he looked at it and he said, well, listen, if we're all doing the same things, we should have the same results. So if you go into the hospital and you have a hip fracture, right? If you go in with a hip fracture, no matter where you go in the country, you're going to pretty much get the same care. Because ortho guys have pretty much, and girls, have shown that you need to get it fixed right away. So that's easy. This is a logarithmic scale. So this is where it gets, I'll explain that to you later, Charles. But what you look at is, on the far right is lumbar fusions, right? It's all over the board. We are horrible. So if someone comes in the hospital with degenerative disc disease, they have a 1 million times greater chance of getting a lumbar fusion if they go to, what do I want to say, Swedish? No, I'm kidding. But I don't know where it is, but I'm just saying it's horrible. And if you look on the left side of this, you'll see that color-coded map shows the variety and heterogeneity of care in the U.S. We don't do our patients right because we're all doing different things. All right. The second thing that happened, and you guys are a little young for this, but this was unbelievable, and Charlie probably remembers this. 2017, the American Board of Neurologic Surgery says, I'm going to change the way you guys do your boards, and we're going to follow the orthopedics pattern. And what happens? You have to bring your cases in. And people came in, they're like, oh yeah, you're going to fail because your cases are not, you did things that you shouldn't have done. But it's really hard to find what indications are, but we'll get it. Our failure rate jumped up to 21%, almost a 30% failure rate based on that. So that's the second thing that piqued my interest. And the third thing is the number of fusions in the US is absolutely one of the fastest growing things that's going on out there. Is that a good thing or a bad thing? And we're not making judgments. I'm just saying these are 3 observations I made. And just to be fair, these are the Jefferson operation numbers. So, call a spade in the sense that I, at Jefferson, was absolutely increasing my rates, the same as everyone else. We decided to do a project and really look at the indications. I'm gonna go through this really quickly. We use, how many guidelines there are for spine indications for lumbar fusion? Anyone? 0. We have to go to the NAS pair performance things to find out the 9 different indications to get a lumbar fusion. And this is the only evidence-based material out there. And the first thing you do when you have a hypothesis is what? Is you test it. So we went out and I made a bunch of different scenarios, sent them out to a bunch of different people, and I said, this patient shows up with this scenario. This is the evidence-based medicine of what you should do. Are you going to do it? Only 30 to 40% of the time did people follow the evidence-based guideline recommendations. So I'm like, okay, we have a problem. Now, why is that? And I'm not going to guess why it is, but I'm going to give you a little, if you're an economist, you might say this could influence people. If you go to a surgeon and you get an operation, you make RVUs. That's easy. If you go to a surgeon and you get a decompression, how many RVUs do you get? We'll say they get X. How many more do you get if you get a fusion? Charlie, never sit next to me, close to me. So,
Probably 2 to 3 times.
3 times, it's like you saw my talk. You get 3 times more RVUs if you fuse someone versus not fusing them. So you get this flow chart that's kind of like, is it really supposed to be as good as we want it, and are the arrows all lined together? And you ain't go, well, the hospital, they're just a building, right? No, the hospital does unbelievably well if the surgeon does fusions. Why? Their DRGs are much, much better paying for the hospital. So the hospital might tell you they don't like fusions, but they love fusions. The only guy that doesn't want you to get a fusion is who?
The patient.
The payer, the patient too. Well, I was going to say the payer wants you dead, right? All right. Next question is, so what, that's a different story. Well, maybe your patients don't want you to operate on them. The next thing that we did is we said, okay, I made a surveys and I said, let's go in there and let's look at the indications. And we went around, we asked different people. And guess what? Same thing happened when we individually had the cases. This is a lumbar fusion. Like this is, I thought was a softball. Guy comes in, drug addict, has that MRI, and he has that. Who wants to fuse him? Oh, who wants to operate on him? Set rate, C rate, discitis, no deformity. Anyone want to fuse him? You would fuse him.
Looks like it's collapsed.
Oh my God in heaven. I mean, obviously you must not have much OR time or you must be awfully bored, but I would be operating for the rest of my life if every guy that comes into Philadelphia with discitis I operate on. Yeah, this guy gets antibiotics our place. Anyways, we looked at it and there are the people that are credence like Charlie that want to operate on him. And so of the people that said they needed a surgery, some people wanted to operate on him. I don't get that, but whatever. No judgment. So again, we did the exact same thing, and I figured this is Jefferson. We're going to have pretty much uniform consensus on the indications and who we do. Had all the attendings, had some of the faculties do it. 30% of the time, only 30% of the time did everyone agree on the right surgery for the patients. And this wasn't like I was trying to trick people. I mean, these were like, okay, guy's got a fracture, this guy's got a lumbar disc. So we had a problem. So I had to figure out how am I going to answer this? And what we did is we used the oswestry. Anyone knows what the oswestry is? Oswestry is the greatest thing. It was made to objectify workman's comp claims. That's what it was. And so what it is it's to present disability someone has for work so they could get paid. Really, that's how the whole form came out. But I use it, and I'll tell you the reason why. So most of your patients with lumbar stenosis or back problems should be looking in between 20 and 35. So when you're doing clinic and someone comes in, like most of my patients at 45 with devil horns on their things, you're like, probably not going to make that patient better. So just be cautious of that. And then the thing we looked at in this, MCID, who knows what the MCID is? Minimally important clinical difference. And what that does is, for oswestry, there's 3 papers. One says 4, one says 5, one says 6. And so I picked 5. It says you need to get 5 points on the oswestry. Now, I only did the 50-point scale, not the 100-point scale, in order to get the MCID. So with that said, really simply, we made an algorithm. You come in, you got 5 points better. It was considered success if not. We did your typical surgery. We looked at everything. We looked at the different indications for surgery, and I'll go through that one second. We looked at the surgeon. We looked at the approach of the surgeon. We looked at if you followed the evidence-based medicine category, and we looked at basic demographics. Patients came in every Monday. We still do this. It's torture for me, but every Monday we go through and we go through every operative case on Jefferson Monday morning. And we look at it, and we look at the pictures, and we look at the surgeon's indications, and we rate if it's an indicated lumbar fusion or not. Now, I just want to give a 2 seconds on my soapbox. Guidelines are guidelines. You do not have to follow the guidelines. If you do not follow the guidelines, that's not wrong. They're guidelines. So to do something that's not in the guidelines is not inappropriate. So with that said and we'll go through this. We made a pathway, and I'm kind of flying through this. We had 325 patients, had unbelievable follow-up, and what we found out is 21 of the patients didn't follow the evidence-based guidelines, 288 did. For example, patient who comes in, degenerative spondylolisthesis, slip, that's an indicated operation. They got fused. They did extremely well. Their ODI improved by 16 points at 6 months. Fantastic success. You know, I always tell my patients, you never want spine surgery. You never want a fusion. But if you have to get one, you want to have a degenerative spondylolisthesis, because I think those patients do the best. All right, next patient comes in. This is a 57-year-old man who someone operated on, exhausted all medical treatments, got a multi-level fusion. He did not do well. His ODI went down. In general and overall, and this is actually pretty impressive, at 6 months' time, 80% of the patients that came in had a positive experience in terms of their lumbar fusion. And that's all comers. About not that much, 5% actually were about the same. 16% declined, which is not a good thing. But the good news is the decliners didn't really, most of them declined only within 5 points. So that's the good news. Long story short, when you look at all the different patients and the different comers, these are by the results. 7% of the patients did not follow evidence-based medicine. And I'm going to go through here. But here's the take-home point. Some of these things you would expect. Revisions did worse. Why you fused them didn't matter. And here's the take-home message. If you followed evidence-based guidelines, you had a chance of getting a 7-point improvement. If you did not follow evidence-based guidelines, you went down to 2%. Well, how about this question? I'm a better surgeon than Charlie, because we all know I'm a better surgeon than him, and that partner's better than that. Because every one of my surgeons, if you ask him, he's the best guy. Did it matter who the surgeon was? Not at all. The surgeon didn't matter. Did it matter the procedure you did? You guys heard Juan talk about different record players and 8-track tapes and cassettes. Does it matter what procedure you do? Didn't matter. Didn't matter if you did an X lift, a T lift, a PLIF, didn't matter. The only thing that mattered on the multi-logic regression analysis is what? If you followed evidence-based managed care. So if you want the highest quality for your patients and the best outcome, follow the literature and follow evidence-based management. I'll skip through this quickly just because this is kind of interesting, just as an aside. I watched my residents go through this, and so if you look, I started it from 4 years in. If you're going to teach residents, serial education is the way to go, because you'll go to see first exam, second exam, first exam thing, and then you go to PGY5s. The PGY5s, what are they? So they came in and they were already there, so they probably already had some opinions. And they said, screw this, I'm not doing this, I'm going into vascular. And so you can look, their scores didn't change that much. It's kind of an interesting thing. All right, now this is the fascinating part of the talk. So you can wake up, 2 more seconds, we're almost over. I got in a fight with anesthesia. I know that's a shock, and it's going to kind of play. My cases started at 7:15. I'm the only attending in the hospital. Sitting there, the anesthesia attending is not in the hospital. 7:20, 7:25. Adam can watch. My freaking head's popping off my thing. The guy shows up 7:30, sees me, and runs into the third room he had to do. My cases didn't get started for 45 minutes. I went acroplex. I mean, my head blew off. So I sent an email to the freaking anesthesia people, and I'm like, you guys, da-da-da-da-da. Okay, I almost got kicked out. I swore all the bad things in the world happened to me. He sends me a response by email. Jim, you are the most efficient surgeon we have. Therefore, we decided to start your rooms last. And I'm like, Okay, I'm not fighting with, after that day, I go, I can't fight with anesthesia anymore. They're the most illogical people in the world. So, my dad was an anesthesiologist, so that could be some of the some Freudian frustration I have. So here's the funny thing. So as I'm arguing and we're sending emails back and forth and I'm dropping F-bombs, this and that, he sends me this graph. And I'm like, what the hell is this graph? Oh, this is Epic. They know all my OR times. They know, because they're hooked up to something called Vision, and that's the University Consortium of Data. And so they know everything about me. I am 32 minutes faster than the national average on T-lifts. And so they know how much your times are and what you're doing. So be very careful as you go. So my junior partner, this slide's out of thing, but we'll come back to this slide. My junior partner, very smart guy, he calls me up one day, he goes, I want to do this thing with costs and analyzing cost of different things. And I go, well, who's the world expert? And he goes, well, there's some guy at Harvard Business School, and he does something they call time-driven activity-based cost analysis. And what's that? Long story short, everything that happens has a cost. So the cleaning person has a cost. So he went around in our OR and he calculated every person that interacted in the operating room, from the janitor to the cleaning person to the nurses, if it's a temporary nurse, medical student, every cost and whatever. And he hired a research person. He's been looking at this. He looked at 19 neurosurgeons at our enterprise. And then the funny thing is we said, what's the simplest thing we could do? So we said, single level ACDFs. Seems a no-brainer, right? And I'm not going to go into all the stuff he does. For the honest reason, I have no freaking idea how to deal with it. His name's Siva, extremely bright. Any questions, ask him. But what he did is he said, I'm going to look at all the surgeons, and I'm going to look at their total cost. And this is what it comes down. This is the end slide I should have, but I don't. The circle, how big the circle is how many surgeries you did. So if you have a big circle, you do a lot of ACDFs. Little circle, you don't. The average cost, we said before, is 1. Remember I said, hey, it should be pretty close? Not even close. A 3 to 4 time difference in the 19 people based on who's doing the surgeon. I mean, who's doing surgery? One thing you could pick out is if you do a lot of something, you're probably going to be cheaper than the group. But that's not a thing. So he went through all the different things. Some kind of funny things that cracked me up. Well, how about you're at the academic center, Dr. Harrop. Your cases cost the most, Charlie. Totally not true. The academic guys are actually below the mean in most of the things. We'll do it at the surgery center. The surgery center costs were higher than everyone else. And I'm telling you this because you're going to hear a lot of things, but you got to look at your own numbers. And you're getting to the age where you guys can know your numbers. And knowing your numbers is leverage. Because if you don't know your numbers, you can't leverage things and change how you do things. Like, again, I made fun of myself and said, I know the cost of everything in the operating room because I've spent that time to do it. So you need to start understanding your pathways and how you do things. And anything that comes in the hospital, I'm on what they call the value analysis committee for the whole enterprise. And so anything that comes in our hospital has to get approved by us. And we ask 2 questions. How much does it cost? And what's the value of the patient? And it's not like we're the cheapest people, but I have to know that someone's getting something for something bought new. And so I keep on telling that to industry is you have to have value. It might be more expensive, but it has to have value. Gets the patient out of, gets the patient recovered faster, makes the patient have a higher quality of life. There has to be some metric for it. So keep on going through this. If you look at the different things, I'm just going to go through this. Personnel costs, fly costs, isn't there that much difference? Except, again, on the left, the people that do the most surgeries had the best outcomes in that way. And the people, there's a couple outliers. We're now going back and trying to figure out who are these outlier people. And I'm going to skip through all this stuff because you guys don't really care. Then the next thing we did, the last thing we looked at was what? I tried to bring it all together. So we got the desk, we finally getting some of the cost stuff. I went to value. And here we go with our old good versus bad. So remember I told you they're watching you? So now we got names, and we got costs, and we got quality metrics. And again, if it's happening at my hospital, which is never first in anything, I can guarantee it's happening to everyone else. So do the best for your patients, understand value, and then I just want to go to one last thing. I'm going to go back to one last slide because I'm going to give you a little example. This is an ACDF. One of the costs we didn't think. How much, Charlie's a bright coder person. There's two options you really have for an ACDF, allograft and a cage. As a surgeon, I use allograft. The CPT codes I get 3.26 RVUs, right? If you use a cage, because it's so much more difficult to just shove the thing in a hole versus burr the stuff down and put it in a hole, you get 7.61 RVUs. So you get paid more if you put a cage. So as a surgeon, you're like, no brainer, I'm gonna put a cage. Now to make it even worse is if you do 3 levels, what do you get using allograft?
Same.
You get the same. It doesn't change with allograft. Does it change with cages? So you get 3 times 7.26, or you get 22. And to be honest with you, it's about $500. So is it a huge deal? No. However, it goes back to my earlier statement of the hospitals and the doctors have to start aligning, because the $500 that the doctor makes, guess what? The hospital now has to pay for a more expensive implant.
You know, at our hospital, allograft is more expensive than cage.
Really? I can tell you at our hospital, it's the other way around. And it's about $200, I probably shouldn't say this, it's about $200 more expensive for a cage than allograft. But if you're a hospital, again, if you're a hospital and you are, a lot of academic places pay the physicians through RVUs, like my hospital does, that means they're getting hit twice. They're paying for the more expensive cage and they're paying the surgeon more. And so you're talking, realistically, in a 3-level ACF, you're probably talking almost $2,000 or $1,000 to $2,000, which again, isn't a big difference, but we really need to start looking at what's the value for the patient and how are we all aligned together. So with that, I think I'm almost done. That's pretty much the last slide. As we step back to summarize, if you want the best for your patient, you should follow the evidence-based guidelines. And again, cervical, thoracic, what is it? It is basically a summary of the literature out there that supports the best care. 2 is cost. I'm not telling you to change anything. I'm just telling you to understand your system around you, because it's gonna change as you guys age. And it's so much easier to change when you're young than it's old. So thank you.
Hey, Jim, that was a great talk. One of the things that you didn't talk about is, you know, when you look at implant costs, this is a small portion of the cost of care. There's actually,
go ahead.
What you don't talk about, and I think you guys will see this, is that the real cost is, look at the administrative cost. I mean, that's exploded. No one ever talks about how much the administrators are making to quote manage these different service lines and do all the statistics. I mean, that's to me the real cost of care.
The overhead.
If you use allograft versus a cage, do you really think that's going to change the world? No.
No.
I mean,
but I am telling you, you probably should have some knowledge of what's going around.
I agree with you.
That's my point.
No, I think this is great, Jim, but I think the people that are driving the healthcare dollars up are the insurance companies and the administrators.
I mean
also, that's my
end of life care.
Right?
I think is also.
And I don't know if Pat and I know Richard gives a good talk on this, but
So I'm going to give you three quick comments. One is bundled care payment. You know what the most expensive thing is? By far, almost 2/3 of the cost is physical therapy, which is amazing. Number 2 is, to go to your point, Joe Chang wrote a paper many years ago, or at least it was an abstract. I don't know if he ever published it. The 2 biggest guys that are accelerating the most, surgeons' fees have not astronomically changed. It's administrators has gone way up, but the other guy is the pain management peoples. their services and costs have really risen like
Injections.
1,000% or something when you
Yeah.
look at it.
The cost
So-
of injections is astronomical in comparison to surgery.
Right. I mean, you've done it. You come in, these guys had 16 epidural shots, and you're like, usually after 12, we stop at our institution.
Okay, thanks very much. So our